Hello, my name is Alistair McNarry. I'm an anaesthetist based in Edinburgh, and I'd like to welcome you to this edition of the Airway Management Podcast from Medtronic, the makers of the McGrath video laryngoscope. In this podcast series, we'll take a deep dive into the multifaceted world of video laryngoscopy, a technique that I think has changed our practice, certainly changed my practice, or dare I say revolutionised the practice of airway management everywhere that an airway might be managed, both inside and outside a hospital environment. In this series of 4 podcasts, we're looking at 4 different things. We're looking at the evidence for video laryngoscopy, the role of video laryngoscopy in pediatrics, teaching and training in video laryngoscopy, and today's special, I'll look at the role of hyper-angulated video laryngoscopy. Join us then as we uncover the versatility and impact of this technique on delivering safer airway management and better oxygenated patients wherever we work. In this episode, I'm delighted to be joined by 2 Patricks, stalwarts of airway management, one from Switzerland and one from Scotland. I'm going to let them introduce themselves. So Patrick from Switzerland, perhaps Professor Schoettker, you'd like to introduce yourself.
Hi, Alistair. I'm Patrick Schoettker from Lausanne in Switzerland. And when I first saw these hyper-angulated blades 2007, I was fascinated. And then I said, maybe this is a device to leave the anatomy as it is and look around the anatomy to better introduce the tubes into a tracheal inlet.
Dr. Ward from Edinburgh in Scotland, I'm afraid you don't get off the hook. You need to introduce yourself also.
So I'm a consultant anaesthetist in Scotland, working at a head and neck centre. From a hyper-angulated blade perspective, I was an early adopter for sure, and it is my predominant laryngoscopy technique these days. And I like to use them for awake, asleep, combined with bronchoscope, pretty much anything I can.
So you've both said that you're video laryngoscopy, hyper-angulated video laryngoscope enthusiasts, but aren't all video laryngoscopes the same? Are they really different?
Well, Alistair, we come from the world of direct laryngoscopy where everything is pretty much the same. And all of a sudden we have these video laryngoscopes with different shapes of blades. And hyper-angulated and Macintosh is a very different technique. And what I like very much about the hyper-angulated is you turn around the anatomy. You leave it as it is, you turn around, you have a beautiful view, and then you better understand what you have to do and what you see. And once you understand, you need to understand the trajectory your tube needs to be to drive into the tracheal inlet.
Now, you spent some time describing what is a hyper-angulated video laryngoscope, but how do you define it? What actually says this is a hyper-angulated video laryngoscope? What's the difference between a hyper-angulated video laryngoscope and a Macintosh-style video laryngoscope?
I think the important distinguishing feature is the curvature of the blade. So separating it from your standard Macintosh standard geometry blade, there's an increased curvature. And generally that curvature is designed to conform to what you sometimes hear is described as the primary curvature, so the oropharyngeal curve, the sort of normal and anatomical curve, which is important, as Patrick has said, because that changes your view and also changes the way you deliver the tube to the glottis. And it separates what previously you would have had with direct laryngoscopy, where the ease of view translates quite well to ease of delivery of the tube. That is not the case with an indirect technique, which the hyper-angulated blade technique is.
You're both very passionate about your hyper-angulated video laryngoscopes. You say there are advantages. What are they? Tell us what they are. Why should we be using hyper-angulated video laryngoscopy in our practice?
Distinct from a Macintosh direct laryngoscope or distinct from a Macintosh video laryngoscope, you really are truly seeing round a corner. Your field of view is up to 60 degrees compared to a direct laryngoscope where you're at maximum going to see 15 degrees from the end of your, either from your eye or from the camera. So your field of view of the entire glottis, but also the surrounding structures is improved. That translates to improvements in terms of reducing trauma, improvement recognizing whether you're in the correct place, like prevention of esophageal intubation, and improves your overall better laryngeal views. And will also increase your first pass success because you have a better view.
So I know that there's an evidence-based video laryngoscopy podcast coming, but just for listeners who haven't maybe had the chance to listen to it, can you just sum up the evidence for hyper-angulated video laryngoscopy in 1 or 2 minutes?
you refer to the sort of 3 axes alignment kind of model of laryngoscopy, aligning your oral, pharyngeal, laryngeal axes. It isn't physically possible to do that, in that your vertebra, your ligaments of your C-spine actually prevent you being able to do that. A better way of looking at it is the model, 2-curve model, a primary curve and a secondary curve. The crucial aspect of the hyper-angulated blade is that it goes around that primary curve. You do not need to require to flatten that curve in order to achieve a view. Normally, when you do direct laryngoscopy or MAC video laryngoscopy, you flatten that primary curve to some extent to achieve the view you want.
Now, with such a weight of evidence, I'm thinking to myself, when should I use a hyperangulated video laryngoscope? Or perhaps easier for our listeners, when do you both choose to use a hyperangulated video laryngoscope in your practice?
There is scientific evidence, and then there are facts. I think as soon as you see better, you understand better. And once you understand better, you probably have a better understanding of your patient's airway. And one patient's airway is not equal to the other patient's airway. So once you position your blade in the right way, you are able to really understand what type of airway, what type of problems you have in front of you, and then maximize the team effect because we're all looking on the screen, and then introduce the tube in a dynamic way. What I think, at least in my understanding and in my learning, what I have learned by using the video laryngoscopes, hyperangulated, it transforms your view of the airway into a dynamic intubation, because you understand how you can actually manipulate the airway, manipulate the blade, and manipulate the tube to insert these tubes into an airway, which is by definition static if the patient is paralyzed and lying back. So I think this is a big learning I have had over the last years since I've introduced video laryngoscopes, hyperangulated in my clinical practice.
So Patrick, I can see you're gagging to butt in on some evidence.
I don't think you can look far beyond the 2022 Cochrane review, comparing video laryngoscopy with direct laryngoscopy, and I know it's going to be spoken about in other podcasts.
So in a minute.
But specifically, when they compared direct laryngoscopy with video laryngoscopy, actually they looked at a subgroup of hyperangulated video laryngoscopy and the advantages. And there are advantages in terms of better views, better first pass success, less trauma, better recognition of esophageal intubation, less hypoxemic events. So taking that just as one single piece of evidence, it would certainly encourage hyperangulated video laryngoscopy use. There are more recent studies which would certainly encourage use as well. There's the 2024 Ritzler study that looks at hyperangulated video laryngoscopy versus direct laryngoscopy in pretty big numbers, in over 8,000 patients in elective surgery, and it's shown better first pass success.
Now, there's been a lot of talk of curves, and certainly in my training, I was used to learning about straight lines. How do we deliver those curves? Let me use my favorite word, stelletiquette. How do you use a stellette properly? We've all seen those case reports of stellettes going in places they shouldn't be. We've read papers that talk about the difference between bougies and stellettes and tube delivery. Tell us about stellettes and bougies and when to use it and when not to use it.
Yeah, it all goes down to being comfortable by using it. So my strong philosophy is the more you use it, the better you understand, and the better you understand the shortcomings, and the better you understand how you can actually turn around the shortcomings. So I'm the head of the ENT anesthesia. In my unit, we use it every day. In that specific instance, all my trainees use it every day, and when there's unexpected difficulty, they actually know and they have in their hands the tool that has been demonstrated being the most powerful and the most useful. So it's no unexpected difficulty, because once they have it, they use the tool which has been demonstrated as being the most powerful in the different literature. In ENT surgery and in ENT patients, every patient gets intubated by the hyperangulated blade.
Excellent. I can think of another question to ask you in just a second. Patrick, when do you pick up a hyperangulated blade?
So I think arguably you could use it for all patients for laryngoscopy. The evidence isn't there to support that, but I think it may well be soon. The other things I would say is certain patients and certain pathologies lend themselves to hyperangulated video laryngoscopy.
Patrick, it seems entirely appropriate to mention your paper and more importantly your video of how you can manipulate a stylet doing something called the tube dance, but you seem to be able to put a tube in any direction you want. Can you tell us about that?
So what we want to do is to understand the movement the tube needs to do to go through the anatomy. First curve, second curve. And evidently the goal of you and the goal we do have is to make the two curves as flat as possible so the movement is as small as possible. In some specific instances for anterior lying tracheal inlet, you need to have the tube go up and down. And by manipulating the tube and the stylet with a specific shape and a specific resistance, you actually will be able to have the extremity of the tube go up and down. That's what I call the tube dance. And if you rotate tube and stylets, you can even move it, have it move right and left. So you need to transform this static intubation into a dynamic by manipulating tube and stylet, which allows you to insert the tube where you want to do it in there.
Patrick from Edinburgh, how do you achieve that? What do you teach your trainees to do?
Yeah, so because of where the camera is placed on the curvature of the blade, you almost always are looking up at the glottis. The trachea, as you rightly say, is not in that same trajectory. So you have to take a tube that's been delivered to the glottis and change its trajectory. Often, by removing your stylet or bougie just a centimeter or two from the tip, you'll allow the tip to fall and that will pass safely through the glottis. The extreme of that is the orotracheal tube dance, but there are other things that Patrick mentioned in terms of left at larynx, right at rings, so you can manipulate your tube on your stylet to facilitate the passage. Essentially, left at larynx, right at rings changes the trajectory of your tube in keeping with the trachea.
So I'm a great fan of guidelines. What do guidelines tell us about using a hyperangulated video laryngoscope blade? Has it made it to guidelines yet?
Yes, they have actually, right? They have finally made it through it. At the beginning, big of criticism because it's a new tool, it's a new design, it's a new technique, especially with related to hyperangulated intubation. And now all of a sudden people start to understand the limits, the good size, and the way we need to manipulate these bougies, tubes, stylets, and blades. They have made it through the guidelines, and they have been demonstrating that actually by using hyperangulated blades, you have a better chance of putting the tube in the right size or in the right site, that is the trachea, or in the other words, say if you put it in the wrong hole, like the esophagus, the hyperangulated blade is a fantastic tool to detect it.
Okay, Patrick, anything to add to that?
The hyperangulated blade certainly appears in the most recent American guidelines for difficult intubation, for predicted difficulty, and also for the rescue of unanticipated difficult airways. It doesn't quantify which patients or qualify which patients that should be used in, but I think there'll be more studies in that area that may be able to shed light on that.
Those older anaesthetists among us will remember that Jack Pacey introduced a hyperangulated video laryngoscope way back in the day. Are we coming full circle? Are we coming around to say everybody should use a hyperangulated video laryngoscope all the time?
I strongly believe yes, but it will take some years.
I suspect you're there too. Is that true?
I'm there too. We need the evidence to support that, though.
Okay, so what is the next study in hyperangulated video laryngoscopy? What would you like to see in the literature?
Personally, I would like to see it used for all comers. I'd like to see very little exclusions in a study, used in emergency cases, used in elective cases, used across the board, at least in adults, and to prove that it can be used in all pathologies and all patients.
So I'm curious to know that you're both clearly hyperangulated video laryngoscope enthusiasts. If hyperangulated video laryngoscopy is so good, is it going to replace awake tracheal intubation with a flexible bronchoscope? Or is it just going to become an awake technique with a video laryngoscope? I don't know how you both feel about that. I think Patrick from Switzerland will let you go first this time and go from there.
Oh, Alistair, this is a hard topic for me because, to be quite honest, I stopped doing awake intubation since I introduced video laryngoscopes. What I do is spontaneously breathing intubation with a hyper-angulated blade, which allows me actually to do a diagnostic video laryngoscopy to better understand what I see and to manipulate then the right technique, identify the technique, and of course the team, which I need to have around me. So I don't do awake, I do spontaneously breathing on patients who are asleep with a special technique.
Now, for those of you listening, I think that's Patrick Schoettker dodging the question. So I will now ask the same question to Patrick Ward and see if we get a different answer.
I don't think it is going to replace flexible bronchoscopic intubations. I think they should be viewed as another tool and should run in parallel with techniques like that. There are certain patients where an awake video laryngoscopy technique may be superior, but not all.
The one question we haven't asked and we haven't really addressed is how you teach hyperangulated video laryngoscopy. And I draw your attention to the fact that there is a podcast on teaching and training. So you can be brief, fortunately, because I think we're running out of time. But how do you teach hyperangulated video laryngoscopy in a few sentences?
I think people need to understand first the primary curve and secondary curve. That is a crucial aspect of it. I think they need to understand that it is distinct from direct laryngoscopy and MAC video laryngoscopy, and they need to practice. So it requires training, but it requires practice.
I'll use that wonderful word from Anders Ericsson, deliberate practice. So not just do they require training and practice, they require teaching. Patrick, how do you teach video laryngoscopy with a hyperangulated blade?
I challenge my doctors, my residents, and tell them, look at the patient, but look at your patient from the side. Visualize the curves, try to understand where the blade will be, what kind of view you will have, and then transform your visualization that you have in a two-dimensional screen into a three-dimensional thinking. And try to understand and visualize the movement that you will have to go through to go into the different steps around the first, second curve, and then into the trachea.
Listening to what you're saying, you're clearly very enthusiastic about using a video laryngoscope, using a hyperangulated video laryngoscope. But it's probably just worth saying to all of our listeners that actually you shouldn't change your practice based on our podcast. Please do go away and study the evidence. Please do go away and think about the devices you're using in your department. But please make sure that you get teaching and training on how to use the video laryngoscope you have in your hand. And don't just change your practice based on the podcast. Change your practice based on the evidence and based on training and teaching and promoting patient safety and airway management. So I think that is about the end of our time here today. I'd like to thank on your behalf Professor Patrick Schoettker from Switzerland, Dr. Patrick Ward from Edinburgh. Very grateful for your contribution and your effort and your enthusiasm. And of course, I'd like to thank our sponsors, Medtronic, for making the whole series possible. But most importantly, I'd like to thank you, the listener, for tuning in and hopefully learning a bit more about the role of hyperangulated video laryngoscopy. If you've enjoyed this, please do listen to the other podcasts in the series. Please tell your friends. Please tell your colleagues. I think there will be a facility to comment below. Please comment and listen to the other podcasts as we investigate how video laryngoscopy is shaping the future of healthcare.